Bismillahirrahmanirrahim. Today's lecture is about diabetic ketoacidosis. Diabetic ketoacidosis is a life-threatening complication of diabetes. Although it mostly occurs in type 1 diabetes, it can also occur in type 2 diabetes. The symptoms usually begin rapidly and can be triggered by infection, stroke, not taking insulin correctly, and medications such as steroids. Diabetic ketoacidosis results due to an insulin shortage, which causes the body to burn fatty acid. This leads to production of acidic ketone bodies. It can be defined as having serum concentration of more than 5 milliequivalent per liter of blood, sugar more than 250 milligram per deciliter, and blood pH less than 7.3. Causes of diabetic ketoacidosis. The common cause are an underlying infection, which count 40%, disruption with insulin treatment account for 25%, and undiagnosed or newly diagnosed diabetes 15%. Categorized based on subtype of diabetes. Causes of diabetic ketoacidosis in type 1 diabetes are insulin deficiency, poor insulin compliance, osmosis of insulin, bacterial infection, stress, maybe medical, surgical, or emotional, failure of insulin infusion pump when somebody has implanted insulin pump and it stopped working, or no identifiable case. In some instance, there is no identifiable cause of diabetic ketoacidosis. In type 2 diabetes, diabetic ketoacidosis can occur during illness such as pneumonia, urinary tract infection, prostatitis, heart attack, and medication like clozapine or corticosteroid. It can also occur in pregnant women who have gestational or pre-exciting diabetes due to physiological change in pregnancy. Pre-existing diabetes due to physiological change in pregnancy. Diabetic ketoacidosis has been found to occur for 14% of hospital admissions of diabetics and 16% of fatality related to diabetes. About 50% of hospital admission among young individuals are related to diabetic ketoacidosis. Mostly seen among type 1 diabetes, the incidence is estimated to be 2 episodes per 100 patient years of diabetes. Developing countries, the incidence of diabetic ketoacidosis is unknown, but is postulated to be higher compared to industrialized nations. Due to poor surveillance in developing countries, the exact data is not known. Incidence has been observed to be high in Caucasian and females. Among type 1 diabetes, it is more common in younger patients. In the United Kingdom, 4% of type 1 diabetes develop diabetic ketoacidosis, while in Malaysia it is established to affect 25% of type 1 diabetic annually. Sign and symptom of diabetic ketoacidosis. Some of the signs and symptoms of diabetic ketoacidosis include increased urine, increased thirst, generalized weakness, fatigue, malaise, generalized feeling of discomfort or being unwell. Malaise means generalized feeling of discomfort or being unwell. Nausea, vomiting, abdominal pain, which may be very severe, loss of appetite, decreased perspiration or sweating, mild disorientation, confusion, and coma. When diabetic ketoacidosis occurs due to an ongoing infection, some symptoms of an infection are fever, chill, breathlessness, joint pain, cough, chest pain, and palpitation. On examination or first look, the patient appears ill, has labored respiration, dry skin, dry mucous membrane, feel cool, and has a characteristic acetone ketotic breath odor. It can be described as fruity smell or like pear drop. Physical examination. Physical examination include assessment of mental status, volume status, and a focus some systemic examination. Patient usually present with sign of volume depletion such as tachycardia, hypotension, decreased skin turgor, and dry oral mucosa. Temperature can be normal or even low in presence of infection, mainly because of peripheral vasodilation. Other physical signs may include Cosmal respiration, rapid and deep breathing. Cosmal respiration means rapid and deep breathing with acetone, fruity breath odor. Alteration in mental status, shock and coma. Diagnosis and investigation. Diabetic ketoacidosis can be diagnosed when there is combination of high blood glucose, hyperglycemia, acidosis, and the presence of ketone in the blood or urine. Then 10% of patients with diabetic ketoacidosis don't have significantly elevated high blood pressure. This is known as euglycemic diabetic ketoacidosis. To detect acidosis, a pH measurement can be performed on blood collected from a vein or artery. Ketone can be detected through the urine and blood. Blood sample can also be used to determine urea and creatinine function to assess kidney function and electrolyte level. A complete blood count and C-reactive protein can be used to determine if there is any ongoing infection. A chest X-ray and urine analysis may be beneficial to exclude other source of infection. A computed tomography CT scan can be used to assess the severity of cerebral edema and presence of stroke. Diagnostic criteria. Diabetic ketoacidosis can be distinguished from other diabetic related emergency due to large amount of ketone in both the urine and blood along with marked metabolic acidosis. Ketoacidosis does not only occur in diabetes but also in starvation and excess alcohol consumption. The American Diabetic Association has divided diabetic ketoacidosis into 3 stages of severity. Mild case have an altered patient, mildly decreased blood pH between 7.25 to 7.30 and decreased serum bicarbonate between 15 to 18 millimole per liter. In moderate case, the patient may be mildly drowsy with a blood pH between 7 to 7.25 and bicarbonate level between 10 to 15 millimole. In severe cases, the patient may experience stupor or coma with a blood pH below 7 and bicarbonate level below 10 millimole per liter. Treatment of diabetic ketoacidosis. DKA is a medical emergency that requires prompt management in a hospital setting. The management includes restoring the circulatory volume, correcting electrolyte abnormalities, treating hyperglycemia, and diagnosing and treating the precipitating cause. Fluid therapy. Patients with DKA are constantly dehydrated. On average, patients with DKA have pre-water deficient of about 100 ml per kg of body weight. Intravenous fluid therapy expands the intravascular volume, improve renal perfusion, and reduce peripheral insulin resistance by reducing level of counter-regulatory hormone. The net result will be a reduction in blood glucose level. Treatment of diabetic ketoacidosis. Normal saline 0.9% sodium chloride is recommended as the initial IV fluid replacement in DKA. Initial IV fluid replacement start with 0.9% sodium chloride at a rate of 15 to 20 ml per kg, about 1 to 1.5 liter over the first hour. Thereafter, the rate and type of fluid is determined by assessment of the clinical condition. Patients with hypovolemic shock or continue on 0.9% sodium chloride at a rate of 1 to 2 liter per hour until their condition becomes stable, while patients with mild or moderate hypovolemia are given 0.9% sodium chloride at a rate of 500 ml per hour for 4 hours, followed by 250 to 500 ml per hour, depending on the clinical condition. Once patient with severe hypovolemia becomes stable, the IV fluid management is changed to the same as those with mild or moderate hypovolemia. Once hypovolemia is corrected, the type of IV fluid is determined by the level of corrected serum sodium. If the level is low, less than 135 millimole per liter, 0.9% sodium chloride is continued, and if the level is normal or high, more than 135 millimole per liter, IV fluid should be changed to 0.45% sodium chloride. The rate of IV fluid in both groups will be 250 to 500 ml per hour, depending on the patient's clinical status such as weight, vital sign, urine output, and the presence of comorbid condition. Once blood glucose reach less than 11.1 millimole per liter, 200 mg per deciliter, 5% dextrose should be added along with 0.45% sodium chloride at a rate of 150 to 250 ml per hour to maintain blood glucose concentration at 8.3 to 11.1 millimole per liter, means 150 to 200 milligram per deciliter. Electrolyte therapy. Diabetic ketoacidosis is associated with a significant total body deficit of serum electrolyte, particularly sodium chloride and potassium. On average, patients with DKA have the following deficit of electrolytes per kilogram of body weight: sodium 7 to 10 milliequivalent per kg, potassium 3 to 5 milliequivalent per kg, and chloride 3 to 5 millimole per kg. The amount and timing of potassium replacement depend on the serum potassium concentration. No supplement is required if the serum potassium concentration is more than 5.2 millimole per liter, 5.2 milliequivalent per liter, but the level should be monitored closely because the entry of potassium in cell would be facilitated by volume expansion, resolution of acidosis, and insulin therapy. Remember, when insulin is given, which is in turn would result in decreased concentration of serum potassium. Once serum potassium level is less than 5.2 millimole, potassium replacement should be started to achieve a goal of maintaining it at 4 to 5 millimole per liter. For levels between 3 to 3.3 and 5.2 mole per liter, replacement should be started using 20 to 30 milliequivalent of potassium in each liter of IV fluid. If serum potassium at presentation is less than 3.3 millimole per liter, insulin should not be started as it can further lower serum potassium, and potassium replacement at 20 to 30 milliequivalent per hour should be given until serum potassium level rises to more than 3.3 millimole per liter. Insulin therapy of diabetic ketoacidosis. Insulin therapy is a mainstay in management of DKA because it reduces the production of hepatic glucose, increase the utilization of peripheral glucose, and inhibit lipolysis, ketogenesis, and glucagon secretion, resulting in lowering of plasma glucose and decrease the production of ketoacidosis. Insulin is usually given through IV route, starting with a bolus of regular insulin at a dose of 0.1 unit per kg body weight, and then within 5 minutes followed by a continuous infusion of regular insulin of 0.1 unit per kg per hour. In children, a bolus dose of insulin prior to the IV infusion is not recommended, as it does not improve clinical outcome and may contribute to the development of cerebral edema. With insulin therapy, plasma glucose levels are expected to reduce by about 2.8 to 3.9 millimole per liter, 50 to 70 milligram per deciliter per hour, or 10% from initial glucose concentration after the first hour. If glucose level does not decrease by these rate, hydration status and rate of IV fluid should be alleviated and optimized if necessary. Once there is assured, and if the plasma glucose level continue not to fall as desired, the insulin infusion rate can be increased by 1 unit per kg per hour until a steady decline in serum glucose by rate described above are achieved. When plasma glucose reaches below 11.1 millimole per liter, 200 milligram per deciliter, the insulin infusion should be reduced to 0.02 to 0.05 unit per kg per hour, and 5% dextrose should be added to IV fluid to allow the continuation of insulin until ketoacidosis is controlled and to avoid hypoglycemia. The rate of IV insulin infusion and the concentration of dextrose are adjusted. 10% dextrose can be used if necessary, aiming to maintain blood glucose level at a 8.3 to 11.1 millimole per liter, 150 to 200 mg per deciliter. In mild to moderate DKA patient, the use of subcutaneous rapid-acting insulin has been found to be safe and effective and can be used as an alternative to IV infusion or regular insulin. In these patients, insulin therapy should be started with an initial bolus of 0.2 to 0.3 unit per kg followed by 0.1 to 0.2 unit per kg every 1 to 2 hours. The dose can then be reduced to 0.05 unit per kg every 1 hour or 0.01 unit per kg every 2 hours until resolution of DKA. Once study with a small number of patients examining the use of IV rapid-acting insulin in the management of DKA and found it to be used effectively if IV regular insulin. Regular insulin is still recommended in management of DKA given its well-established studies and low cost compared with rapid acting insulin and complication of diabetes. Diabetic ketoacidosis can be associated with several complications such as sepsis, diffuse ischemic process, myocardial infarction, heart attack, deep vein thrombosis called DVT, esophageal urinary tract infection, acute gastric dilatation, late hypoglycemia, hypophosphatemia, and cerebrovascular accident called stroke. One study also indicated that pediatric patients who have type 1 diabetes who have had diabetic ketoacidosis tend to display lower cognitive function after treatment. The researchers from this study have suggested that either diabetic ketoacidosis or its treatment may have resulted in neuronal insult that has an effect on either acute and possibly long-term cognitive deficit. Future management and care. Those with infection should be given antibiotic. The patient who has infection, he should be treated with antibiotic. Management of complications such as cerebral edema, cardiac dysarrhythmia, pulmonary edema, or myocardial heart muscle injury should be managed appropriately. An endocrinologist can be consulted to help assist with management once the patient has been adequately stabilized. Any change in the mental status in pediatric patients should indicate the possibility of cerebral edema. Long-term frequent monitoring of blood glucose level at home decrease the likelihood of diabetic ketoacidosis. One study concluded that diabetic ketoacidosis patients who were admitted to a pediatric intensive care unit had excessive insulin dosing, improper fluid resuscitation, and lack of proper laboratory evaluation. Prognosis. The fatality rate of diabetic ketoacidosis is 0.2% to 2%, with most residing in developing countries. Fatal cases usually present with decreased urine, deep coma, and decreased body temperature, hypothermia. Prognosis is worse in older patients with ongoing illness, especially if treated outside an intensive care unit. Diabetic ketoacidosis patients who are treated properly have excellent prognosis, especially in young patients without infection. Properly treated diabetic ketoacidosis rarely produce residual effect. The fetal mortality rate associated with diabetic ketoacidosis is as high as 30% with coma. The rate is as high as 60%. Best results are observed when the patient is treated in intensive care unit for the first 2 days. So thank you. Please subscribe the channel, down the bell icon, and write down your valuable comment in the comment box for the improvement of channel.